All right, everyone, with our next speaker, I'm happy to introduce Dr. Ghosh. She is an assistant professor of bariatric medicine at the Johns Hopkins School of Medicine. She's internal medicine trained with specialization in rheumatology and obesity medicine. With extensive experience in clinical practice and research, she focuses on integrating health strategies that address obesity that will improve the health of employees. I will now pass on to Dr. Ghosh.
Thank you. Thanks for that great introduction. I'm one of the physicians who works here at Hopkins in obesity medicine. So we're going to touch on a lot of different management strategies for obesity medicine today. So a little bit different. All right, so we're going to talk about guidelines. We're going to talk about different treatment options, and we're going to go over evidence, especially talking about anti-obesity medicines today and the evidence behind them. And it's no surprise to everybody here, I'm sure, that there's a high prevalence of obesity and that there's screening guidelines that we're trying to diagnose obesity and overweight. But why are we focusing on obesity? We see that here that half of patients are even receiving counseling by their primary care physicians. And so if people don't have a diagnosis, if it's not addressed in a healthcare setting, it's very hard to kind of be preventive, to get ahead of some of the comorbidities that are associated with it. And I'm sure everybody here knows there are many, many comorbidities that are linked to obesity. When we think about obesity, and the adipose tissue almost starts acting as its own endocrine organ when there's a community of those cells together, right? Sending out inflammatory signals all over the body. So it's really important to remember and reframe for patients that we're talking about a chronic, relapsing, progressive disease. And that is something that's pretty modern for us to think about even. And there's a lot of kind of old-fashioned thinking sometimes in medicine and bias in medicine itself, right? So we know that every system is affected by this chronic disease. So again, why do we think it's important to know the guidelines around this? It's because often the percentage weight loss that we're thinking about with patients is much lower than what the patients themselves think that they need to achieve to get better health, right? So when we're thinking about even just 3 to 5% weight loss, that's going to improve glucose, triglycerides, it's going to help with progression to diabetes. And when we're thinking about that 5 to 10%, that's going to help with blood pressure as well as with cholesterol. So you don't actually need these high percentages to achieve meaningful outcomes for patients. And so when we're talking to patients in the beginning, we're often thinking about expectation setting and trying to think about that first initial goal before achieving some of those higher percentages. And also talking about what is realistic at a population level, right? What is a goal rate of weight loss? So often that's between half a pound and a pound a week, over the course of a whole month. That's a lot slower than many people think when they come to our clinic. Okay, that's an achievable goal, that's a safe goal. So a big part of this is having that discussion and kind of partnering with your patients so that they don't lose motivation along the way, right? And then of course the comorbidities, whatever the other things that you're treating in these patients who have a diagnosis of obesity is important to think about for our long-term outcome goals. All right, so we talked a little bit about those percentages and why those are meaningful. And then of course, there are some patient populations where we're thinking about higher percentages. So especially in cardiovascular disease or in things like idiopathic intracranial hypertension, sometimes it's more meaningful to have greater percentages of weight loss, or in severe osteoarthritis, some of these kind of other diagnoses, we might have a higher goal. So we know now that there's a big difference between different patient populations and what we're targeting. How do we integrate all of this together? So the Edmonton obesity staging system is something that we're trying to use more and more in our clinic. It's not only looking at a BMI, which can be very limiting, right? Not everybody with the same BMI has the same health status. So we're trying to look at other comorbidities and how severe those comorbidities are to understand what we're targeting with different patients. Okay, and kind of bringing this back to the clinicians, to the providers, right? Again, a lot of providers are not comfortable talking to their patients about weight loss. And why is that? I think a lot of providers, the evidence suggests, feels like they're not equipped to have those discussions. They feel like it's not meaningful, that they don't see change in kind of patient outcomes, and so it's not something that they want to spend time on, or that they don't have time in their visit to talk about. Okay, and then, from the patient perspective, there's a lot of stigma associated with healthcare, right? A lot of patients who have a diagnosis of obesity are doctor shopping, they feel dismissed. People spend less time with them when they do come into a clinic visit on average. People spend less time building relationships with these people. So of course, they have hesitancy about, even bringing this topic up with their providers when they've had these stigmatizing kind of associations with healthcare in the past. And the physical clinic environment itself, often when we look at different clinic environments, there aren't the right sized cuffs for blood pressure, there's not the right size equipment, not the right size chairs for patients to sit in. So we need to accommodate patients for them to feel comfortable in our clinics. And then obviously, when people don't feel judged, they're gonna have more success. They're gonna have more meaningful discussions, they're gonna engage more, it'll be a true partnership. Okay, and there's a lot of frameworks that already exist that we know are evidence-based for having these discussions with our patients, right? The 5 A's, motivational interviewing. I'm guessing these are not new concepts, so I'm not going to go into them deeply, but we have a lot of strategies of how to approach these conversations. And then it's also important to be able to talk about what tools are available, right? We know that we can talk about lifestyle, we can talk about those anti-obesity medications, metabolic bariatric surgery. Most of the time our patients are most interested, or the majority of our patients are most interested in talking about lifestyle. So it's important to meet them where they are and kind of understand their goals. But it's also important to know the evidence behind these different categories of interventions as well, especially if we're thinking about comorbidities and people who are in a higher risk group. So again, we're looking at some different guidelines here. And our first intervention that we're going to talk about is this high intensity comprehensive lifestyle program. It's important to know what actually counts as a high intensity lifestyle program. So having at least 26 hours of intervention with somebody who has an expertise in a year, or 14 sessions in 6 months. And finding these community resources are often very difficult. And we see that the weight loss outcomes are actually quite significant when somebody engages with one of these programs. And these are very similar guidelines, different organization, but there's a lot of evidence behind supporting people for behavioral intervention, right, and outcomes with that. So connecting patients with those, knowing what's in your community, and then also knowing what actually falls into that category. And then it's possible for us to do counseling as well, right? So understanding what the data is behind nutrition, knowing that, it's really not about one diet strategy or one specific intervention that tends to make a big difference with nutrition. It's more about finding out what's going to work for someone and what's going to be sustainable. So any intervention really, it doesn't have to drive a very significant amount of weight loss. If it's sustainable for somebody, it's going to help with their health outcomes. And then there's lots of data on different strategies we can use to help with nutrition tracking as well. And then physical activity, I think important to help patients understand that it's very important from a heart protective, lung protective standpoint, but it's not going to drive the majority of weight loss. It's going to be very important for weight maintenance. So talking a little bit about weight maintenance, this is often where people start to get frustrated because we see that there's often plateaus that people reach along the way. And so it's important to kind of know what goes into long-term weight maintenance. And also that at a population level, when we're looking at people who are successful with weight loss, it's very common that there's going to be some weight regain over time. So again, when we're thinking about realistic long-term outcomes, that 3% goal is often what we're going to see people achieve, even with sustained lifestyle change. So how can we change those outcomes long-term for somebody who we think needs more of that 5 to 10% or even above the 10% marker? So we're going to talk a little bit about anti-obesity medications, right? Because evidence really shows that weight loss is greater in that year to 18 months, and weight maintenance is greater up to 3 years. And there's more and more data saying that even longer than that time period, that those interventions, those tools, like medications, like surgeries, like minimally invasive procedures help to support people with these long-term changes. And it's very complex why that is. And, I put in a lot of this neuroendocrine kind of pathways that play into that with the different medications that we're gonna be talking about. But we're not gonna go in depth with that piece. We are gonna talk about the evidence behind the different medication strategies. So when do we think about putting a medication on board, right? If somebody's having trouble with just lifestyle change, right? They're not necessarily having that pace of weight loss of the half pound to a pound a week on average that we expect. Or they've cycled through the same things over and over again and they've had weight regain. Or there's another comorbidity that makes it very important for them to achieve a more dramatic weight loss. And in general, if we're using those BMI cutoffs, we're thinking about having these discussions with somebody who has a BMI of 30 or more, or having those discussions with someone with a BMI of 27 if there are certain comorbidities. So let's talk about the different drug categories. Super important to remember and emphasize to patients that this is in addition to all the lifestyle changes that we were talking about earlier. Right? When we're using a tool, many people think, oh, it's going to be a solution, but they have to have a nutrition strategy, they have to have regular exercise, the stress management, the sleep, all of those components are really the pillars of long-term health, right? The medications I think about allowing their body to respond differently to the things that they're doing from a lifestyle perspective. And there's a lot of monitoring that's involved, right? So if somebody is started on a medication and they aren't having the response that I expect, we need to change strategies. Not everybody's biochemistry is going to be the same. Not every medication category is going to work for everybody. So it needs to be a dynamic plan over time. Okay, and then it's very important when we're starting medications to have a discussion about what that long-term is going to look like. So when I talk to patients, especially depending on which medication category I'm talking about, I'm thinking about, is this something that you're willing to do as a chronic medication, or is it something that you're thinking about more as a short-term option, because that's going to change the trajectory long-term. Okay, so into the specifics. So the centrally acting anti-obesity medicines, meaning they work on kind of that neurochemical pathway that we saw earlier. So phentermine, when we look at data at 6 months, typically helps people lose about 6% of their body weight. And you can see some of these other outcomes that are associated with it. There are definitely side effects that people notice. So there's some of the common side effects here, like dry mouth, trouble sleeping, sometimes headaches or anxiety. And then we're looking here at kind of a big table that I'll bring your attention to. This is the lowest out-of-pocket cost for patients, right? So if they don't have coverage, often we'll be thinking about phentermine as a sustainable option for them. When we're using like a good RX coupon, for example, phentermine is often going to be $18 a month less per month. So for many people, that's something that's going to fit into their long-term budget. Okay, and now we're talking about phentermine and topiramate. So a little bit different combination here, but some very good trial data on this. So about 12 months in, we see 10.9% weight loss. And there's a lot of other indicators that it's helping from a health perspective, right? That inflammation is coming down in the body, that blood pressure is coming down, that cholesterol is coming down, and waist circumference as well. Does it come with side effects? Some patients do notice that they have some tingling in their fingers, toes. Sometimes some of the same side effects that you'll see with phentermine. And with all of these centrally acting medicines, you can see changes in mood. So it's very important to monitor how somebody feels. Right, and then you can see in some of these real world examples too, that often the mean weight loss is actually higher in a setting where there's some lifestyle component, counseling and support for patients. Okay, and importantly, it's very important to tell people that if they're a woman who's in their fertility years, that they need to use some sort of contraception, because we know topiramate is not a good drug for babies. Okay, and then naltrexone bupropion. So at that 12-month time point, there's about 6% weight loss here. Again, you can see a lot of other things are impacted by this, but this is not a great blood pressure control medicine. So again, comorbidities really help us decide which of these medication categories we're thinking about. And some of the side effects here, it can have some similar side effects, even though it's not a direct stimulant in the same way that phentermine is. Can sometimes see some of those headaches, constipation, nausea. And specifically, when I'm thinking about naltrexone and bupropion, I'm thinking about slowly up titrating, which is true for many of the different categories that we're thinking about. The side effects can be very limiting if we are trying to go too quickly. So often, I think when people have less exposure to using these medications, they try to get people up to that highest dose as fast as they can and kind of follow the trial data, which is wonderful, but there's a high dropout rate from those trials because not everybody can tolerate those medications at such a quick pace of increase. So it's always okay to slow down because again, long-term, we want the tolerability to be okay for somebody to continue on this medicine. And often people still get some benefit from lower doses. So even if somebody never gets up to the high doses, often it's going to help with some of the neurochemistry that's going to help them with the weight loss and weight maintenance. Okay, and then you can see that we're going now into our GLP-1s here. So liraglutide is the first of this category here. So at 12 months, we see about 8% weight loss. And very interestingly, right, we see that actually the weight loss with liraglutide is less than with phentermine topiramate. So sometimes I think when patients come in, they've read about different medicines, and it's important to know which of the category of medicines actually has what outcome, because not every GLP-1, for example, will have as great weight loss as people necessarily think from looking through the kind of media coverage. You can see that it does bring down inflammation again, right? The blood pressures, the cholesterol, the waist circumference all come down. And then we're going to see that the side effect profile for all of the GLP-1 receptor agonists are pretty similar, right? We'll see some nausea, some diarrhea, some constipation, a lot of digestive side effects there. Although these can have mood impacts as well, usually not significant mood impacts. Okay, and then with the liraglutide, it's important to know a couple of things, right? One is, as with all the GLP-1 receptor agonists, how you have your nutrition plan set up has a big impact on whether people are going to have side effects or not. So having small, frequent meals, having enough protein, having enough fiber, drinking plenty of water, all of those things are really protective against side effects with the GLP-1s. So setting up a plan before, having a structure, having support while people are starting on these medicines, help protect them from kind of having so many side effects that they discontinue something that might be beneficial for health in the long term. Okay, and then semaglutide, the trial data is a little bit longer here, right? So for 16 months, we see about 15% weight loss. And again, a big change in some of these other factors like waist circumference, right? That side effect profile, pretty similar, but we're seeing, we'll see soon that this is getting now closer to kind of surgical outcomes or some of those other minimally invasive outcomes through a medication. Okay, and then we can see too that there's some really interesting data that's come out more recently, right? Like the SELECT trial that shows that cardiovascular risk goes down by about 20% for people who have a history of stroke or heart attack or peripheral artery disease. We know that progression of chronic kidney disease is less in patients with type 2 diabetes. We know that heart failure symptoms are less in people with preserved ejection fraction heart failure. So a lot of other conditions aside from obesity are going to be affected by this medication. Again, picking the right drug for the right patient population, important. And then we can see too that, when we look at the trial data for some of these other comorbidities that sometimes happen with the diagnosis of obesity, that actually the weight loss is often less, but the outcomes are still very great for those other disease processes. Okay, and then tirzepatide, which is still the newest player at this point. So 17 months, we're going to see about 21% weight loss. And we're looking at waist circumference change of about 18.5 centimeters. So we're talking about pretty significant numbers here, right? Same side effect profile. Prevalence is less in the tirzepatide group versus semaglutide or liraglutide group, but the same side effect profile for all of them. Okay. And then importantly, there's some other trial data, right, that it helps with sleep apnea, that it helps with metabolic associated liver disease. And patients often come in asking about, if it's not covered by insurance, because we're going to talk about that's one of the big barriers to accessing medications. What are my options here, right? And there are some saving programs that are out there, but we're often still talking about $400 to $550 a month. as a long-term cost for people out of pocket. So it's very, very important, again, to have those discussions up front about, is this really a sustainable treatment option for you? And then this is a table kind of summarizing. I also put orlistat on here, which is a fat absorption blocking medication that is out of favor these days, but still does help with somewhat with that weight loss in the long term. There's a lot of randomized control trials that have been looked at for all of these different medications, and you can see versus placebo how much greater that percentage of weight loss is for each of these. And then also the other outcomes, because again, I think we get really focused on that number, that scale number and the BMI when, it's a little bit limited as a health status indicator, right? We need to look at the big picture. What are the other comorbidities? How well controlled are those other pieces? And then some of the side effects that we know about and the dosing as well. Okay, and then just a shout out to kind of doing a full medication review, right? Because there are a lot of categories of drugs that we know are weight gain promoting. A lot of the diabetic medications, beta blockers are probably the most common cardiovascular medication. So it's important to look through and see, are these all medications where the positives are outweighing the negative of using this medication specifically? And if it is something that you need for other health conditions, can you help balance it out in some way? Not necessarily with anti-obesity medication, but even trial data shows things like metformin for some of the antipsychotic medications, for example, can help prevent the weight gain associated with it. And you can see it's very common that people are often on these weight gain promoting medication categories. Right, and this again kind of summarizes, there's a lot of tables out there that go through, knowing the difference between the weight gain potential of metoprolol versus carvedilol, for example. Does somebody need to really be on metoprolol specifically? Can be really helpful, and I think a lot of physicians don't know those things, right? So if you're talking to someone, you might be the only one that they've talked to that actually knows that side effect of the medication. And then devices, or before we get to devices, access problems. So this is nothing new. Again, a lot of it depends on insurance coverage, what people have the ability to access. We talked about some of the lower cost out-of-pocket options, but some of those come with big downsides, right? Some of those are contraindicated in certain patient populations. Can you use phentermine in somebody who has atrial fibrillation, for example? Not a great idea. So if somebody doesn't have a low-cost medication option, we're going to talk about some of the other tools that we might consider. And there's a lot of media coverage, let's say, of these different medications right now. And so people come in with all sorts of their own kind of bias when they're thinking about this. So very concerned about long-term side effects, very concerned about, what this is going to do, let's say, to kind of their body composition, right? So there's a lot of things, I think, out in social media that play into people's decision-making around medications. And then coverage is probably the biggest driver, and then supply has been a big problem over the last year or two with many of these medications. So people come on and off medications because of access. And then again, we talked about that realistic expectation setting. So, if people have expectations that are not being met, they're often going to get disappointed and stop using medications and then see that weight rebound. So it's really important to have those discussions before starting on medications about what you're looking for and what achievement really is, what a victory really is. Okay, so let's talk a little bit about some of the procedures and devices that are out there. So the intragastric balloon is a temporary option. So if somebody needs to, for example, be a candidate for a knee replacement, and the BMI is the one thing that's preventing them from getting there, and they're in a lot of chronic pain from that, right? Sometimes something temporary can be helpful for them to achieve the goals that they need to be a good surgical candidate, for example. And this is open to people who have a BMI of 30 to 40. And at 6 months, you can see often about that 14 to 20% weight loss versus a placebo. So it can be a pretty powerful tool. The downside of a balloon is that it needs to come out by 8 months, regardless of which brand you're using. And that often people are going to see weight regain after the balloon comes out. And it comes with all sort of complications as well. So often people will feel that balloon is kind of taking up space in their stomach, they feel uncomfortable, they might have some nausea, more acid reflux. All of those things are possible. So a little bit less common to see balloons these days, although it's still possible to have. So minimally invasive, right? What are our options? And the endoscopic sleeve gastroplasty is becoming more common these days, especially since it's now covered by Medicare. So for people who are not good surgical candidates, right? High risk for anesthesia, the endoscopic options are much safer, much lower risk for them, and still have pretty admirable outcomes, right? So at 12 months, we're looking at 12 to 20%, and our internal data usually shows at least 15% weight loss. And it's open for people who have a BMI of 30 or greater. So it's a lot more accessible to many people whose insurance, for example, doesn't cover, for example, bariatric surgery until their BMI is above 35 or 40, depending on their comorbidities. And it does still reduce that stomach size. So it's more of a reductive surgery than a metabolic or a reductive procedure rather than a metabolic option. And we're going to talk about some of the more metabolic options that are out there. Okay, so bariatric surgery. It's important to note that even though most insurance only covers bariatric surgery for people who have a BMI of 35 or greater with comorbidities or above 40, actually, the indications have been updated to people who have a BMI of 30 or greater, or a BMI of 35 or greater, without comorbidities. So it has been shown to be very helpful long-term for a group of people who often don't have access through insurance for it. So we'll see if that changes in the future. And it's very important to know where you're getting your care from as well. And these are the different options that are out there. It's not all inclusive. There are some other ones that I didn't put on the list, but these are definitely the most regular ones that people have as an option when they go to a bariatric center. So the adjustable gastric band, which has fallen out of favor a little bit because revisions are more common, still helps people typically lose between 20 to 25% of their body weight. It's just restrictive, so there aren't metabolic things that are going on. There's not changes in, their ghrelin or their GLP-1 or some of those other neuroendocrine hormones that really make some of the other procedures a little bit more effective long-term. And the gastric sleeve helps people on average lose between 25 to 30%. Again, it's not a metabolic intervention. And so when we look at long-term outcomes with this, we'll see that especially after like that 2 to 5 years, there's going to be a higher percentage of people who are going to have some regain after this intervention. But it is by far the most popular option at this point. Right? It's easy to perform, it's reproducible, it doesn't involve a lot of long-term follow-up, which makes it, again, a very popular choice when people are going for bariatric surgery. Then the Roux-en-Y gastric bypass is a more malabsorptive surgery, but also has big metabolic implications, right? And so we're seeing that mean weight loss is anywhere from 30 to 35%. And we're going to see on our next slide here that some of those comorbidities, there's a huge change, right? The weight loss is one small piece of it, but in terms of diabetes resolution, blood pressure, high blood pressure resolution, long-term cholesterol, all of those things tend to be much more normalized, a very big change over time. And then one of the newer procedures, the single anastomosis duodenal ileal bypass, right, is called the SADIE-S for short, is one of the newer options that has the biggest outcomes, right? So we're looking here at 35 to 45% weight loss in the long term. And this is also quite malabsorptive, but it only has one anastomosis. So in terms of complications and long-term kind of malabsorption, vitamin deficiency, osteoporosis, all of those things, it's much lower than with the gastric bypass, for example. So again, those powerful metabolic effects without some of the long-term complications that we worry about with other options. Okay, and then, again, we can see some pretty incredible numbers in terms of resolution of things like diabetes, hypertension, sleep apnea. So we're looking at often, if somebody's been diagnosed with diabetes in the last 5 years, there's a very, very high probability that they will never have a diagnosis of type 2 diabetes that's active or not under good control after having a bariatric intervention. So that's a pretty powerful incentive for many people when they know about that outcome. And then also people just feel better. They're able to move more. Their quality of life on average, they report is better after some of these interventions. And there's a decreased overall mortality. And it's a very low risk surgery. So I think a lot of people go in thinking, oh, it's going to be a big surgery like a knee replacement or a bypass. And we often see that the surgical outcomes are most similar to something like removing a gallbladder laparoscopically, right? So complication rate, not super high. There are other things that can happen long term, right? It's very important, again, that people have structure and follow-up because it's easy to get vitamin deficient. It's easy, to get osteoporotic if people are not taking all of the calcium and vitamin D and the other things that they need to, or not doing weight-bearing exercises, right? So again, all of these things are wonderful tools if they're in the right context. Okay, and then, of course, depending on what the whole picture looks like, it'll have a big kind of impact on what we think is the best intervention for somebody, not just with surgery, but with any of these things, right? And then there's more trials going on now with combining things like medications and surgeries or minimally invasive procedures and outcomes. And it's looking like the combination of those things are going to have higher percentage change over time, better metabolic outcomes than either one alone. But, more data to come on that in the future. And of course, insurance factors play a huge role in all of this, right? Our treatment planning has a lot to do with what's covered because that's going to give people access or make things inaccessible. And then this kind of goes back to that pyramid we were talking about earlier. So I think about this as important for us to share with patients just for information sharing purposes, right? So that they know what that landscape looks like, they know all of what's available to them. At the same time, that foundation, that lifestyle intervention is going to be important for everything else. So that really is the driver of all the health benefits. Those other tools like medications, like endoscopic procedures, like surgery, all of those things help that lifestyle piece to be more effective, right? Have a metabolic impact so that people can see a response more to the lifestyle piece. And then this is just a summary of kind of depending again on BMI, which again is only a small part, but some of the guidance from those guidelines we went through earlier of at which stage you're going to talk about what, right? So when people come in with a diagnosis of overweight, right, especially if they have some other comorbidities, you're going to talk a lot about lifestyle. You're going to make a nutrition plan. You're going to talk about exercise and sleep and stress so that they feel supported, and also, that changes outcomes for people, right? You're in a non-judgmental, safe space partnering with your patient. And then you're going to also take a look at their medicines because so many medications have metabolically disruptive effects that we ignore. And then if somebody has a little bit more elevated BMI, then we're going to think about things like those medications as an adjunct to the lifestyle pieces that we already talked about. And even minimally invasive procedures, depending on kind of, again, what insurance coverage look like, what their long-term goals are, what some of the other comorbidities are. And then finally, in our last category here, with a BMI of 35 or above, where we know the cardiovascular risk is so much higher, then we're going to think about a little bit more powerful tools, right? Do we think about something like a bariatric surgery intervention along with, again, that counseling, that structure? And I tried to leave plenty of time for questions because I didn't want to go too much into detail with all of this. But feel free to let me know if there's any specific things from this presentation that we touched on briefly that you'd like to hear more about.